Hi, this is Sunil Mankad from the Mayo Clinic. It's a pleasure to participate in the American Society of Echo Board Review. We revised our talk on quantification of mitral regurgitation and added some hemodynamic assessment this year. And I have no disclosures. Now, it's always confusion and unclear terminology when you're dealing with mitral regurgitation. There's all these terms like trivial, trace, mild, mild to moderate, moderate to severe, moderately severe, severe, industrial strength, and then torrential. Then there's semi-quantification, and people use terms like 1 plus, 2 plus, 2 to 3 plus, 4 plus, etc., but it really is still very much semi-quantitative. Now, mitral regurgitation really has 4 hallmarks where we can get a little bit more quantification. The first is the flow convergence zone. The second is the flow acceleration area. And the second is the degree of turbulence, or the amount of turbulence that's in the left atrium compared to the size of the whole left atrium. And of course, there's also downstream effects. Some of these are quantified and some are semi-quantified. We'll start with turbulence, or the jet area. This is the amount of area that the mitral regurgitation jet occupies in comparison to the left atrial area. And this goes way back in the days of pulse Doppler. We could pulse how far back into the left atrium the jet went and give it a numerical quantification of 1 plus, 2 plus, 3 plus, and 4 plus. And then in the era of color Doppler, we could see the area that it actually occupied, not just how far back it went into the left atrium, and once again give it a semi-quantification score of 1 plus through 4 plus. And the American Society of Guidelines has definitions for mild, less than 20% of the left atrial area, moderate, 20 to 40% of the left atrial area, and in the past it was greater than 40% of the left atrial area to be severe. Now that's been revised by the valve guidelines of the Journal American Society of Echo and Dr. Zogby, and now it's 50% of the left atrial area is the definition of severe. And just to show you some examples, here's an example of mild mitral regurgitation. And when we actually measure the area, we get about 14% of the total left atrial area. Now the question is here, is this mild or moderate mitral regurgitation? And if you do the actual measurements and measure the area, we're going to end up with about 32%. So that is in the moderate range. Here's an example of a severe mitral regurgitation jet. And when we make our measurements, it's 50.92%. But you can understand the limitation of this technique. If you have a very big left atrium, the mitral regurgitation jet may not occupy too much of the area. Furthermore, one of the great limitations of this technique is when you have an eccentric jet, and there's what we call a Coanda effect, where the jet hits the wall and loses energy, and therefore it doesn't occupy as much of the area of the left atrium as it might. Now, we can measure this in multiple views, looking at it and getting the full caliber of the jet, and I think everybody qualitatively would see how this jet wraps around the tip of the left atrium here, and we would know that this is severe. But nonetheless, it's a limitation, the size of the atria and the Coanda effect in eccentric jets. In addition, it's affected by instrumental factors. We have to set the Nyquist limit to 50 to 70 centimeters per second. If we're too low, we'll make the jet area larger. The color gain is important. If our gain is too high, we'll make the jet area larger. The gain too low, the opposite will occur. And once again, the size of the left atrium is very important as well. So we'll move on to the next hallmark, and that's the vena contracta. Well, what is the vena contracta? It's the zone of flow acceleration. It's the narrowest point of the jet that occurs at or just downstream from the orifice. And there's definitions of that width of that jet for severity. If it's less than 0.3 centimeters, it's mild. If it's 0.3 to 0.69 centimeters, it's moderate. And if it's greater than 0.7 centimeters, it's severe. And the guidelines now also recommend doing a biplane vena contracta, and if that's 0.8 or greater, that is in the severe category. And this has been validated. This is data from Paul Grayburn many years ago now, looking at angiographic grade versus the vena contracta. And you can see it's a pretty good correlation, 1, 2, 3, 4 plus angiographic grade with the width of the vena contracta shown here in millimeters. In addition, he correlated it with regurgitant volume, and there's a pretty good correlation. It's not perfect, but it's pretty good. So this technique does work. But the big limitation of this technique is shown with 3D echocardiography, because the jet is not a circular jet most of the time. And you can see there's a narrow vena contracta here in the middle, whereas it's wider here on the side. And truthfully, when you're just doing a 2D vena contracta, you don't know where you're making that measurement. So 3D vena contracta has now come about, and there have been numerous publications regarding this. And you capture a 3D pyramidal data set, usually a multiple beat acquire, so you get a higher frame rate. You then take it into multiplanar reconstruction, get the widest orifice, get it at the right timing of the cardiac cycle, zoom in on it, and then you can measure the 3D vena contracta area. This is just being now utilized in clinical trials, and I think will eventually make its way into the guidelines with definitions and cutoffs, and I think we should all learn how to do it. But there is no universal cutoff for mitral regurgitation 3D vena contracta area. It's a little bit different if it's functional and degenerative, but there are plenty of publications now showing that you can easily do this. Now, we also want to quantify residual mitral regurgitation after structural heart procedures. And this is the document that was published in JACE in 2019. Once again, Dr. Zogby is the first author, and it very nicely goes over the best techniques we have, and also some additional imaging techniques such as MRI for quantifying residual mitral regurgitation. I'm not going to go into that right now. We'll focus on more what the board will ask us. Now, there are three quantification parameters that we need to look at. The first is regurgitant volume. The second is the effective regurgitant orifice, or EROA, effective regurgitant orifice area. And the third is the regurgitant fraction, and we'll go over those. We'll start with the continuity equation. This is a conservation of mass principle that if we measure the stroke volume going into a particular chamber, and we do that by calculating the area of a particular region and the pulse Doppler by TVI of that particular region, whether it's the LV outflow tract or the mitral annulus, we can then calculate the stroke volume of the LV outflow tract and the stroke volume of the mitral annulus. And here's just pictorially how we do that. To get the stroke volume of the LV outflow tract, we measure the diameter and we measure the pulse Doppler in the left ventricular outflow tract. We know there are limitations and it's not always circular, but nonetheless, this is the technique we utilize. And similarly, to get the stroke volume of the mitral valve, we measure the mitral annulus, as shown here. Some people do it in a biplane format. At Mayo Clinic, we generally use just one plane. And then we measure the pulse Doppler, very importantly, at the mitral annular level, not the leaflet tips, and we measure the modal TVI. So if we know how much blood goes from the left atrium into the mitral valve, into the left ventricle, that's the mitral valve stroke volume, and we know what goes out the left ventricle, the left ventricular stroke volume, the difference must be the mitral regurgitation volume. So here we have the calculation of the mitral valve stroke volume, the calculation of the LV outflow stroke volume, and these parameters must add up and be equal. And if we just shuffle the equation, if we subtract the LV outflow tract stroke volume from the mitral valve stroke volume, we'll get our mitral regurgitation volume. So let's go through an example here. We calculate the LV outflow tract stroke volume. We measure the LV outflow tract diameter. We measure pulse Doppler in the LV outflow tract, usually from an apical view. We make sure there's no aortic regurgitation because that will mess things up. We then calculate the stroke volume. You can go pi r squared or take 1/4 of pi times the diameter squared times the TVI, and that will give us our left ventricular stroke volume, in this example, 96 cubic centimeters. We then do the same with the mitral valve, measure the annulus, write pulse Doppler at the annulus, and measure the modal velocity. We then calculate the mitral valve stroke volume in a similar fashion, and this is our mitral valve stroke volume. We then subtract our LV outflow tract stroke volume from the mitral valve stroke volume, and we're left with our mitral regurgitation volume. We then can take that mitral regurgitation volume and divide it by the total mitral valve stroke volume, and that will give us our mitral regurgitant fraction, in this particular case, 40%. We then can take our mitral regurgitation volume that we measured and the TVI of the mitral regurgitation by CW Doppler, divide this by this, and that will give us our calculated effective regurgitant orifice, in this case, 0.38 centimeters squared. Now, there are some problems with the continuity method. You have to have good Doppler alignment. If the theta is greater than 20 degrees, you'll be off. Make sure you place the sample volume in the right place, especially with the mitral annulus. It shouldn't be at the leaflet tips. It must be at the mitral annular level. If you don't measure the mitral annulus correctly, so let's say there's a lot of mitral annular calcification, then you'll square the error that you made in that measurement. You have to trace the modal velocity, especially of the mitral valve. Now, we make geometric assumptions that it's a circular annulus, and we know in real life that may not be true. If there's greater than mild aortic regurgitation, you can calculate stroke volume from the other side of the heart, the RV outflow tract, measuring the RV outflow tract diameter and the TVI of the RV outflow tract. And if you have arrhythmias, it gets very complicated because you really need to average quite a bit of data. So let's move on now to what I think is probably one of the best ways to quantify mitral regurgitation, and that's the flow convergence method, or PISA. Well, what is PISA? It's derived from the hydrodynamic principle stating that as blood approaches a regurgitant orifice, its velocity increases, forming concentric, roughly hemispheric shells of increasing velocity and decreasing surface area. Now, that's if you have a circular orifice. That doesn't always occur, but you do get these hemispheres, and you can set your aliasing velocity to have these hemispheres bloom and then make your measurement. This is called the proximal isovelocity surface area. Depending on your aliasing velocity, and you will shift this towards the mitral regurgitation, you'll get different sized hemispheres and different quality hemispheres. We then will also need to measure the peak velocity of the mitral regurgitation by CW Doppler. This is from Dr. Zogby's guidelines once again, showing very nicely how you shift the baseline towards the mitral regurgitation. That will cause blooming of a hemisphere, which we can then measure. And if we know that radius of that hemisphere we just measured, and we know the aliasing velocity that we have set, we can then calculate regurgitant flow, 2 pi r squared times v. We then can calculate the effective regurgitant orifice area by taking that regurgitant flow and dividing it by the peak velocity. We can then calculate the regurgitant volume by taking that ERO and multiplying it by the TVI of the mitral regurgitation velocity by CW. Now, it's important when you use PISA to zoom the region of interest. It'll decrease the error of the radius measurement. Shift the color baseline in the direction of the regurgitant jet and make sure it blooms into as good a hemisphere as you can get. Shift the baseline for an optimal hemispheric flow convergence signal. So for example, here's a larger zoom box, and this is not a bad PISA. And note also that there's not a really hemisphere. It just gets cut off right here when it's like at 180 degrees. But if we zoom in further, look how much nicer a PISA we can get. And we can make that radius measurement much better. 2 pi r squared times our aliasing velocity will give us regurgitant flow. Now, it doesn't matter if you have good quality data, though. You can take your different aliasing velocities, as shown here, and you'll have different size hemispheres and different R values. In this case, we had a radius of 0.99 at an aliasing velocity of 25, and these were the values that we got. But look, even if we use a different aliasing velocity of 38 centimeters per second, now we'll get a smaller radius, but the ERO and the regurgitant volume are very similar. The advantages of PISA is that it can be used in the presence of other valvular regurgitant lesions or shunts. It can be used in the presence of valve stenosis or prosthetic valves, and it uses fewer variables. Now, this is a very important slide, and it just needs to be committed to memory before you take your boards. What are the cutoffs for each of these particular quantitative parameters? The mitral regurgitation volume, 60 cc's. Regurgitant fraction, 50%. The ERO, 0.40 centimeters squared. And the vena contracta width by 2D, 0.7. If you did a biplane, it would be 0.8. But these need to really just be committed to memory prior to your taking the boards. Now, there is a simplified approach to PISA, and the way this works, it's a mathematical situation. If you set your aliasing velocity to 40, and if you assume a peak velocity of the mitral regurg of around 500 centimeters per second, which is usually the case when the LV function is preserved, then a lot of these parameters drop out. And then all you have to do is look at 0.5 times r squared when you're at this particular aliasing velocity. You don't have to worry about any other calculations, and that will give you the ERO. Then, if you know the particular aliasing velocity that you set as 40, if your radius is 0.9 or greater, you're going to have severe mitral regurgitation. So if you set your aliasing velocity to 40 in the direction of the mitral regurg and your radius is 0.9 or greater, it's probably severe mitral regurgitation. Now, when do you use this? Use it when there's sometimes an eccentric jet that you just can't quite line up your CW with, and so you don't get an accurate peak velocity of the mitral regurgitation. This can happen in the OR when you're doing transesophageal echo as well. So let's look at this example. This is a 48-year-old female, has a heart murmur and dyspnea. And you can see there is mitral valve prolapse, no question about it. Bileaflet mitral valve prolapse. And there's some degree of mitral regurgitation. There's no aortic regurgitation. If this is the Mayo Clinic format or ASE type B format, and it looks like there's quite a bit of mitral regurgitation. But if you notice, there's a lot of mitral regurgitation, but only for a brief period of time. So we can do our PISA calculations. We'll zoom in on it. We'll shift our baseline, which we've done here, and we'll bloom our hemisphere. We'll zoom in on it and make our measurement. And at an aliasing velocity of 61, which is still pretty high, our PISA radius was 0.5. So then we can calculate our flow, 2 pi r squared times v, and their flow is 96 cubic centimeters per second. The sonographer then made this measurement of the mitral regurgitation TVI by CW. While the peak velocity measurement is okay, look at this. There's nothing here, but we're just tracing it because we think that's what the mitral regurgitation curve should look like. But you got to trace what's there. This TVI of 179 is erroneous. Why is that? This is a particular entity of mitral regurgitation known as late systolic or mid to late systolic mitral regurgitation. You can see here's the QRS and systole begins, and there is no mitral regurgitation. And then towards the end of systole, there's a lot of mitral regurgitation, but it's only present for a very brief time. And in fact, the correct way to trace this CW for TVI is actually trace what's there. Don't imagine what the curve should look like. And in this case, instead of 179, we got 127. And then we can do our calculations. Remember, we took our flow, which we measured from the PISA, divided by the peak velocity, and our ERO came out 0.17. You can then calculate the mitral regurgitation volume by taking our ERO and multiplying it by the mitral regurg TVI. And when measured correctly, this gave us a regurgitant volume of only 22 cc's. Oftentimes with this late systolic MR, your ERO may be much higher than your regurgitant volume. And you should always use the regurgitant volume firstmost in this particular entity, late systolic MR. Now you can use the continuity equation as well. So once again, we'll calculate stroke volume in the LV outflow tract. We'll calculate the mitral stroke volume. And we subtract the LV outflow tract stroke volume from the mitral valve stroke volume, and that gives us a regurgitant volume of 26 cc's, very similar to the 22 cc's we had with the PISA. We can then calculate our regurgitant fraction by taking the MR volume and dividing it by the mitral valve stroke volume, and it's 25%. Everything is very consistent. We can then calculate the ERO by taking our mitral regurgitant volume and dividing it by our TVI, and now we get an ERO 0.20. Very similar to what we got with the PISA method. Now, there are problems with PISA. There's suboptimal flow convergence, non-hemispheric flow, multiple MR jets. Some eccentric jets may impinge on the hemisphere. The LV outflow tract may be obstructed and distort the isovelocity convergence zone. PISA is dynamic during systole, so timing is crucial. You should always find out where your peak velocity is on the CW, correlate that with your EKG on the ultrasound machine, and measure your PISA at the same time. And some people think it's just too complicated for routine use. One of my mentors, Dr. Pandian, likes another four-letter word for PISA, cluelessly reasoned assumptions principle. And you can see what the four letters mean. Now, this is part of the reason PISA gets a bad name. This is an amorphous blob. You cannot make a measurement of PISA on this particular entity. You either got to change how much you shifted the baseline and really get a much tighter hemispheric view and zoom in much more as well. Now, I mentioned that if there's zone impingement, you have problems and you have to calculate for that. Now, some eccentric jets will not have zone impingement or hemisphere impingement. But in this particular case, there is. The wall is impinging on our hemisphere, so it's not a full hemisphere like we would really like. There is a way to calculate that, and it basically gets very complicated, but then you have to use kind of a protractor and measure this angle, and that's your alpha divided by 180, and you can get your measurements. But remember the supportive signs and the hemodynamic burden of mitral regurgitation. If it's chronic and it's severe, you should have an enlarged LA. You should have an enlarged LV. Your peak E wave velocity should be greater than 1 or even 1.2. And don't forget the downstream effects. Here we see a nice example of pulmonary vein systolic reversal of flow, which doesn't always correlate with severe MR, but is definitely a supportive sign. Now, the importance of loading conditions in the hemodynamics of mitral regurgitation has been mentioned previously, but I just wanted to show you another example. This is a Mayo Clinic format, the left ventricle with ischemic cardiomyopathy, and this patient has MR and dyspnea. Here is the mitral regurgitation. I'm not going to waste time doing a PISA, but it's quite severe, as you can see here. But Dr. Robert McCulley at my institution did an intervention, and now look at the mitral regurgitation. It's much, much less. Well, what was that intervention that Dr. McCulley did? He gave this patient isosorbide mononitrate and then further up-titrated it, and now the patient has really only mild, with some beat-to-beat variability, mild to moderate mitral regurgitation. The load dependency of functional MR is very significant. That can really show itself in the operating room. Here's a patient that had recurrent flash pulmonary edema due to severe mitral regurgitation. In the OR, under general anesthesia, these are her vitals: blood pressure 100/60, PA pressure 35/20, mild mitral regurgitation. We then gave the patient some phenylephrine, just got the blood pressure up to 150s. Now the PA pressure is in the 70s, and there's severe mitral regurgitation. And look what happened on 3D echo. This is a view from the left ventricle, and that's a nice way to look at functional mitral regurgitation. So from the left ventricular perspective, this is the medial area, or P3. And you can see there's reduced excursion of P3. But look what happens when we gave the phenylephrine. The orifice area is so much bigger. And in fact, mitral regurgitation will usually be downgraded by at least 1 grade in the operating room. So most of the decisions need to be made ahead of time, or perhaps a phenylephrine challenge. There are data to support that. We would like to make that decision ahead of time if at all possible. So my final points. If it's a mild, well-visualized central jet, it's mild. You probably don't need to quantify. If you suspect more than mild, you should analyze. Use all the available info. No method is perfect. And if you're still uncertain how bad the mitral regurgitation is, have a low threshold to do cardiac MRI or left ventricular angiography if there's any doubt. Learn to quantify. It's a responsibility we have to our patients and colleagues to produce a report closest to the truth. And I like this quote from Soren Kierkegaard: "To dare is to lose one's footing momentarily. Not to dare is to lose oneself." I've also included in your syllabus from the 2020 ACCHA guidelines, first authored by Dr. Catherine Otto, the indications for intervention in both functional and degenerative mitral regurgitation, primary or secondary mitral regurgitation, primary being degenerative. And I thank you very much for your time. We will go over other examples during the question-answer period in calculations of the severity of mitral regurgitation. Thank you very much.